Hello, 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 hello. Welcome back, welcome back, welcome back, everyone. Hope you had a nice poster session. Welcome back, everyone, in person and online. It's now my pleasure to introduce our speakers for the final talk session of the day, towards the social neuroscience of music therapy processes and outcomes. Before I introduce our speakers, I do want to say you should have taken your poster down, and if you didn't, we do need to clear that room right now. Our helpers will be doing that, so if you didn't take your poster, it will end up at the registration desk, I guess, and you can find it. And if you still don't take it at that point, we're going to throw it away. So make sure you get it if you want it. Okay, so in this session, we have the pleasure of hearing from two speakers, Dr. Jörg Fachner and Dr. Clemens Maidhof. So Dr. Fachner is professor of music health and the brain and co-director of the Cambridge Institute of Music Therapy Research at Anglia Ruskin University in Cambridge, UK. And I actually met Jörg 10 years ago when I was a student in Cambridge. There were joint meetings across the Cambridge Institutes, and I was very excited to talk to Jörg because he had just published a paper showing that listening to music reduces eye movements. So since then, we've seen each other in various other countries and meetings, and it's really a pleasure to be able to welcome you again here today. Dr. Fachner has worked over 25 years in music therapy, psychology, and medical research projects in Germany and Finland and the UK, and is a specialist for translational research topics in the social, medical, and music sciences. He's keen to use technology to investigate the social neuroscience of music therapy and has secured over $3 million in funding to analyze the emergence of change in moments of therapeutic interest. So the goal here is to add and analyze contextualized data to what is otherwise typically considered anecdotal evidence. So he published the first music therapy hyperscanning paper demonstrating the importance of moments of therapeutic interest, which is super high impact. You could see is in the top 5% of rankings for that journal. So it's a really cool work, and I'm looking forward to hearing more about what he's been up to. Dr. Fachner holds UK Research Council funding in the UK and Austria to realize a music theory-specific neurolab setting adapting to music therapy practice. So as a situationalist, his pragmatic approach is to capture the real-world idiography of the therapy process with continuous multimodal data streams, which includes ECG, EEG hyperscanning, all kinds of exciting stuff, some themes we've been talking about over the last 2 days. And now I'll switch to introducing Dr. Maidhof. So they're going to talk together, and I won't do a separate introduction in the middle of their talk. So Dr. Maidhof is a senior research fellow at the Cambridge Institute for Music Therapy Research, Anglia Ruskin University in Cambridge, UK. Previously, Dr. Maidhof worked at the University of Cologne in Germany, the Finnish Center of Excellence for Interdisciplinary Music Research in Helsinki and Jyväskylä, and the Max Planck Institute for Human Cognitive and Brain Sciences in Leipzig, Germany. He holds an MA in musicology from the University of Cologne and a PhD in psychology from the Freie University in Berlin. Clemens' research interests lie in the cognitive, social, and affective neurosciences of music. He's published papers on error monitoring in music. See, there was an error there just to keep you on your feet. In music performance, utilizing EEG, 3D motion capture, and musical MIDI data. Additionally, he's conducted research on the neural mechanisms underlying syntactic processing of music and language, and the effects of attention on these processes. His current research focuses on the neural dynamics underlying music improvisation and social interaction during music therapy. For this work, he combines music therapy research with approaches from social neuroscience, such as hyperscanning. So we're super excited to have both of these great speakers here today and to learn more about their social neuroscience approach to music therapy. So please join me in welcoming Dr. Fachner and Dr. Maidhof.
Hello. Yes, thank you. This is really a great honor for us to be here, which is the place where the paradigm shift is happening. Well, be careful in saying words, but well, I was always really struck from the developments, and I'm really happy that we can be here to present our work in music therapy and about the social neuroscience of music therapy outcomes and processes, or to turn it around. Yeah, and to see you all here. Well, I shouldn't get lost in some introduction. Well, what I'm going to do today, or what we are going to do today, first of all, well, I think it's important that we have a bit of an overview on what's going on in music therapy, because it's not a unified practice. there is a lot of different approaches, and that's what we have to keep in mind, and also in the way then how practice is processed. And then going to speak about mechanism of change, process, and outcome a little bit. And then Clemens will go into our EEG case studies, 3 explorative EEG case studies, and then I will come back to speak about the patient and therapist perspectives, what we already have in the case studies as well, and about an EEG feasibility group study in a hospital setting where we brought a mobile hyperscanning setup into a stroke unit and to record there. With a particular approach on music therapy, and then if time allows me to go into the motion energy analysis work that we're doing, that one of our PhD students is doing, and also on ECG synchrony, and then go into the outlook into the kind of the future theme that we have here today. Right, so what is music therapy? And so the definition of the World Federation from 1996 is that music therapy is the use of music and its musical elements, sound, rhythm, melody, and harmony by a qualified music therapist with a client or a group. And this qualified may make you a little bit, why is that? Why is he saying that? Well, of course, there is a training that a music therapist has gone through so that he or she is able to get in touch and work with a client or with a group or with a patient. And that all happens in a process designed to facilitate and promote communication, relationships, learning, mobilization, expression, organization, and other relevant therapeutic objectives in order to meet physical, emotional, mental, and social and cognitive needs. You see, I'm reading the slides, so you can go along with me. Maybe I could be quiet, but I'm not. All right. Okay, so music therapy aims to develop potentials and or restore functions of the individual so that he or she can achieve better intra or interpersonal integration and consequently a better quality of life through prevention, rehabilitation, or treatment. Okay, and that's already quite a lot, I think. It's quite a broad way of looking at things. Well, and so to kind of organize that a little bit, I think what we're looking at, so one of the approaches, the Maidhof approach, Maidhof music therapy approach, I've grouped them into flexible approaches because they're quite interactive, quite situated, quite working in the moment to respond to what the patient's needs are. And then we have fixed approaches, not kind of saying that this is, which is based on diagnosed activity. So let me go back to the Maidhof. So it's active music making, improvisation, it's minimal talking, and as Bruscher, one of the music therapy theoreticians, said, it's music as therapy. So where the music is doing the job and not necessarily talking as we would have that in those approaches that have a strong part of psychotherapy aspects as well. Although, for instance, in analytical music therapy, improvisation is done, but it is more or less like music in therapy, so in a therapeutic, psychotherapeutic setting. And then we have a receptive approach. It's guided imagery in music, where it is music listening and talking about the imagery that emanates from the listening, and then talking about these themes. And we will go into a few of these examples, or a few examples. And this is again music in therapy. Well, then in, let's say, behavioral neurological music therapy, music supported therapy, music medicine, we are often seeing that it is based on a diagnosis, and then there's using treatment manuals with successive levels, which is not necessarily what you would do in the interactive settings, because you're deciding on the spot in the moment to what you're doing next. And it is maybe physiotherapy-driven musical activity goals that we're looking at. And when it comes to, let's say, music medicine approaches, and I'm totally aware that I'm kind of really superficial on that, and I know how much interaction is going on in each of these approaches, but I think for opening this up, that what is music therapy, I think it is needed that we are kind of describing a little bit of the practice. And for instance, then a feature-based dosages could be a decision made in a music medicine approach, where you select particular music that has a particular tempo with the intention to induce relaxation. And one of the features is that you not necessarily would be working with a therapist, and this is definitely what you would do in the other approaches there. Bringing an example of a study, so a psychodynamic approach. So in the Finnish Center of Excellence, where we did several music therapy related studies as well, that was a model that was based on a Jungian and a Freudian framework, and with supportive and resource-oriented emphasis, and there it was combining clinical improvisation and talking, to say that in this case, when we were looking later on how much talking was in the therapies and how much music making, for instance, and that was also published then in the British Journal of Psychiatry, well, 70% of talking and 30% of music making, and that would be different in an neurofluence model, where you would be playing most of the time not talking, so that's why I'm saying that. Okay, so, and there we have a free and referential starting point to the improvising, and a free instrumentation, and it's possible to listen to the recorded improvisations later on, if you want to do that, and you can see some of the publications doing that. And yeah, why I'm showing this also, and you may want to listen, is, well, we are recording, and we have been recording the media data in the session so that we can analyze that, and we come back to that later in one of our analysis, because that gives us some process data that we then can relate to the brain processing data. So I just play a little bit of that therapy setting. Get the idea. I'm stopping there. So that was work with depressed patients, and so we were deciding to have only these instruments, because often music therapists choose, well, to play their instruments and work with that, because they can convey the work in a particular way better than but here, because of standardizing and for treatment fidelity, it was of important that we only use also these instruments for the therapies. Okay, right, I spoke about the neurofluence approach, and so a typical situation, you have a setup with drums and piano, I show that video, and free clinical improvisation. And then after the session, you may sit down and write down scores about parts of the session that you think that were of importance, and then, describe the musical elements of that, and in order to come back to it in the next session, so that you can make use of that. Or you could also do some rating scales on the musical interactivity. And so what I'm showing now is a video, and that's quite an old one, because in one of our first studies that we were doing there in the 90s, we were using video VHA tapes and just put this SMPTE sync with the physiological data to overlay that for the analysis of a mock therapy session, because that wasn't what you will see later is real work with patients, but here to look into the way how the therapy is delivered. Yeah, and that goes on then, and so you can see a little bit how that then for the graphic analysis, and later on, because all the recordings, of course, were done on the tape recording, and then looking into that how synchrony developed over time. So maybe an interesting article to look at if you're interested in that. Okay, next, speaking about guided imagery. Well, what is it? It involves spontaneous imaging in an expounded state of consciousness to pre-designed programs of classical, it's also jazz music, it depends on what the practice or what the therapist or who the therapist is, but usually it is a huge amount of playlists that have been created over time and have an empirical base. And when you're trained as a GM therapist, you know how to use, or which kind of playlist you're going to use. So you're listening to that and spontaneous imaging while interacting with a guide who uses non-directive, non-analytical, music-based intervention within a client-centered orientation, or within a session that has a preliminary conversation, a relaxation induction, guided music experience, a return and post-load. For those who were on the poster session, of course, saw the poster that was also dealing with that and have been maybe discussing already with that. The traveler, or the patient, in this case, because it's guided imagery, is sometimes called the traveler, is usually lying down with eyes closed in a recumbent position. Yeah, and commonly you have particular phases or parts of the session that have particular meaning for the patient, and that will become a focus in the therapy process where we start discussing about that. And as you can see, well, this is from our study where we then applied the hyperscaling, and of course, as you can see, well, the patient is lying down, so that was quite a good, let's say, practice setting to start with. And we come back to that, but now you can listen to one of the parts and how that would be. They are talking about the imagery, and then there comes a part where they are quiet and a particular image emerges, which is of importance.
This is a nice person. Like something copied from my grandmother's.
Yes.
Like she telling me not to worry so much.
So I stop that here. We'll come back to that later on. Okay, so you may get the idea that there are several different practices, of course. So when you look into what has been published on music therapy, you will see that there's a lot of studies that have already been published in terms of RCTs, or a good amount of Cochrane reviews, which then, of course, are using sufficiently powered studies to study the pre and post change of primary or secondary outcome measures, and agreeing to that Cochrane idea of the levels of evidence, where the expert experience is the lowest evidence and a randomized controlled trial would bring out the highest evidence, and by comparing macro outcome measures and pre-post intervention to see how effective that is. And that makes sense to be comparable in the treatment world, which is around there. And but this is not necessarily telling us about what is happening in the music therapy. So process research to study music therapy interactions to determine the components that drive the change of the patient. There's a question, so what is important in the session? As a therapist, you know that. So this is where we, of course, are looking into what the therapist thinks about sessions. Then study the moment-to-moment interaction with microanalysis, or then go into that time series analysis. We've seen a few examples, of course, today, and we'll show later. And one of the questions is, when we research on music therapy action on patients, what's the role of the therapist? They seem to be quite important. Well, that's what we know in psychotherapy research as well. The therapist seems to be of importance for the induction of change. And change is, of course, of importance not only for us in terms of explaining it, but also for the patient, because the patient is not coming to you just to get a nice study, but he wants to have change. And so where is the action mechanism? In the music, in the therapist-patient relationship, therapia in the Greek sense means you have to walk with your patient through that darkness, and be a companion that helps. So the therapy ethos is like, well, you're there to really kind of, you do like a contract, and this cheesy word of healing means, in this case, in the German word Heilung means that you are really trying to help to achieve this goal in a way. So is the action mechanism in the setting, if it's community work, groups or diets? in the agenda of the sessions, so how the sessions are set up. I spoke about these fixed approaches, where there's a clear agenda, how it is built up, and that makes a lot of sense for some diseases, but not necessarily in a psychiatry, in a depression study, as we've done that there in Finland. And so there are approach-specific differences in the delivery of the therapy. And when you look at the research settings, well, we have a patient that comes in with his or her music perception, history, preferences, and experiences, and there is a continuous interaction in these flexible approaches and empathy process. So because you're reading the body language of the patient, you're responding to that, and you try to make sense of that all at once and just for the sake of the patient. So that is what you're driven from. So the demands of the patient are superior. So that means if you come in with a particular study design question, and that would be guiding the therapy, well, it already starts to be not a therapy anymore, because it's, let's say, your goals that you are trying to achieve then. And so one of the experiences that we had in that study there in the depression study, we had 20 sessions, and after the 20 sessions, of course, the patients wanted to go on, but that was the end of it, because that was the dosage that we were interested in, of course. And there, in 2-arm studies, patients may not receive music therapy and then drop out. So this is, well, that's the typical business of an RCT, and of course, no double-blind protocols are possible. So if we look at the process of change, we have at least two kind of interacting views on it. One is a more normative view, where we try to formulate a general law. We want to find out a more general description of how that change works. And for that, we study, of course, the change between the subjects and focus on selected macro outcome measures, whether they are usually for an RCT, you have one primary outcome measure, and then you have a set of secondary outcome measures that also may include biomarking in a pre-post sense, and then an assumption of a fixed relationship between two time points, and then you start analyzing the variance, covariance, multivariate, whatever you want to call it then, to understand what the error there is. So I like that very much from Antici, statistical analysis that work on the group's means, treating deviations from the averages as an error or unexplained variance. However, and that's the point here, these deviations represent the personal trajectories and land shapes and shapes of change of each patient. And that's what you know as a therapist, this idiography, which is built and shown in cases or in small N studies where you try to measure change with each individual to create a more local rule. So, and accept that there is a personal nonlinear narrative and trajectory of change. And yeah, it is an observing of the real world settings, and you've just seen a little bit of those that I was showing. And there to analyze the time series within and over sessions. So what I've just described within this ideography container is a bit of where we are coming and where we are going to, while, as I said already, there's a lot of studies that comes when it comes to the RCT side of studying change, where we were where music therapy, we know that means how much you identify with the topics, but I mean where it was shown that that music therapy has an effect. Well, the question then is, when we were publishing this, okay, it seems to work, but how? So even though that I did, pre-post resting state changes, looking into for alter symmetries and from midline theta as biomarking depression and anxiety and other measures there, it still does not tell you what is really working in the session. And so in the Cochrane reviews, you have to bring up an explanation how you think how the treatment may work. And so the action mechanism of active music therapy for depression is that the co-created musical relationship between the therapist and the patient or the patient group enables the patient to experience and to gain insight into relational or emotional problems by talking about the musical dialogue. Synchronization and attunes musical expression can modulate the levels of stress and anxiety into subjective moments from the basis for development of subjectivity, togetherness, creating of meaning, and so on. What you already see is we're talking with terms where we don't have data from within music therapy. So that was one of our missions that we felt, well, we need to have data that shows that. Well, the first data from the depression study where we were analyzing the media data, the music therapy toolbox, which is measuring the synchrony measures of, and we come back to that, so I shouldn't get lost in there. So all these measures will give us a more, let's say, descriptions of all these more non-verbal processes that are happening in music therapy. So, and well, what is happening and how it is done? Well, we're playing, sharing of of musical instruments, singing while being attuned to the patient's behavior and expression. And then, yes, the improvisational techniques to engage with the patient. So you have opportunities for pulse, rhythmic, dynamic or melodic patterns and timbre to be mirrored, reinforced. Well, we may know all that from our studies in music sciences and music psychology or music neuroscience. But in the moment when you have to decide, you know, what allows for moments of synchronization between the therapist and the patient is really driven from that interaction in which you're sitting there and giving the patient's musical expression a pragmatic meaning within this context. And yeah, you can provoke expectations or patterns that have been jointly developed in order to elicit specific social communication behaviors. All this is possible to develop and enhance social communication skills. So yeah, but how to study that and how to get closer to data that really shows these processes that seem to be ephemeric, or that, like in the beginning when you said what was very important for the patient that she heard the voice of her grandma. Well, that may sound really cheesy when you think about, is that really the change? But for her, it was quite an important part of the change, and as we will show that later in the data there. So how to get there? Well, one of the ways is that we know that music therapists report about change in case studies, and they describe parts of a session as a narrative of therapeutic change process in therapy. So, and certain clinical relevant events might be indicative of clients' development in therapy. So this, you know, if you look at this graphic here, so imagine that's a 30-minute session. So you have an event happening after, let's say, 7 minutes. And as a therapist, you know, there's a connection to this event, but not necessarily to that one, because that is related to that narrative of therapeutic change as you see it from the stance of the therapies. And that may be related to an intensity or an emotional intensity or a rhythmic density, whatever you want to bring in there. But what we know is we have an event that is of therapeutic relevance. It is a moment of interest, and that can be compared to a moment of no interest. So it gives us a good possibility to study that. With our neuroscience tools or with the EEG and so the way how we were setting it up, so we have with the brain vision analyzer, of course you have the camera which is related to the video module, so we're recording during the session, and then we had a video set up on the face of the patient, of the therapist, so that we can then study also interaction and gaze, and then recorded that. And yeah, and then after the therapies to do interviews to find out about the dyadic events, context factors and meaning, and to also with the patient and with the therapist identify this moment of interest, these clinically relevant events, and to look at that non-verbal interaction. Of course, it gives you from the video, body language and the contextualized interpunction. I like that very much because the way how you start one behavior and then get a response from the patient, and then again respond as a therapist. Of course, range of causality, all these things come to your mind that we could study, but it's all when you're going straight with this data into a therapy session or the recordings. You can only do that later on, but you need to be prepared to have really captured what is happening in the therapy, so that you can look into the dyadic processing and to analyze the time series of these events in order to describe synchronization, as if that is what you're interested in. And to get there, finally, after a few years after that study that I was showing with the heart rate in the 90s, and seeing Victor Miller's research coming out in 2009, always thinking, well, we should be able to do that with an EEG to study interactive patterns with that EEG. Well, after all, we have been able to do a few things and got some funding from the Ars Humanities Research Councils, where we said, well, we need to rethink and transform medical paradigms to understand creative outcomes and treatment processes by observing the clinical practice in situ when it is happening, when it comes to the therapies. And just as a small example, I mean, it's nothing against what we've seen here in the last 2 days. So how our observation booth and the music therapy unit was changing. So pre and post, getting the money for having all these things to do the studies that we were working on. And now, with the next one, Clemens is going into our GIM study that we've published, and where we try to show you a little bit of how that is done. So I'm now handing over to you.
Yes, hello. So, I'm going to present the results of 3 very explorative EEG hyperscaling single case studies. And the first one was with a receptive form of music therapy, namely guided imagery and music. Jörg mentioned that earlier. So just as a small reminder, this therapy form consists of music listening to pre-recorded music. And the client is usually laying down, eyes closed, and important are the spontaneously occurring imagery, often associated with memories and emotions. And even though it is music listening, it is an interactive situation, and the therapist accompanies and guides the client through the imagery process, for example, by encouraging and deepening the client's inner images, emotions, and thoughts. And a couple of words about the session. So the patient's motivation for the session was to find out how to cope with feelings of helplessness and anxiety. And the reasons for those feelings were due to a very difficult situation, namely the diagnosis of a life-threatening illness of her son's pregnant girlfriend. And the surgery has been put on hold to keep the child healthy, but there was the risk of losing the unborn child or the daughter-in-law. And based on these circumstances, the therapy goals were to be present to the patient's situation, to provide supportive music experience that could contain the patient while exploring strong emotions. And for that, a particular selection of pieces was chosen, which was compiled with the goal of providing a nurturing music experience, and contained, for example, pieces by Britten, Vaughan Williams, Berlioz, and others. And after the session, we asked the patient, the therapist, and 2 external raters, music therapists, to watch the session recording, and asked if they can identify 3 moments of interest, or the most important ones, in the session. And you can see here the outcome of that procedure, so with all ratings plotted over time of the session. And you can see relatively easily that all 4 raters agreed on 2 segments that they seemed or thought were of importance. And to give you an impression about the session, some general comments by the external raters, who said that it was a very moving session with rich images, colors, memories, feelings, body sensations, and messages. And the themes of the session were trees, roots, family history, females, reproduction, and love. And the patient herself described, for example, one moment of interest that was a pivotal moment for her, in which, as Jörg already said, her grandmother was singing and had the message for her not to worry too much. And the therapist also mentioned feelings of being very close and connected to the patient, especially during certain parts of the session. And these 2 overlapping moments during the session then guided further analyses of the EEG data. So, because our main interest was in emotional processing, we analyzed the frontal alpha asymmetry, which can be regarded as a central marker of emotional experience. and it is measured by comparing the power and alpha band in left and right frontal brain areas. Increased left frontal activity associated with more positive emotional experience, increased right frontal more with negative emotional experience or withdrawal-related behavior. And in the context of music therapy, the FAA recorded in resting states has already been used as an outcome measure. Jörg mentioned that RCT with patients with depression, and there the FAA was changed after music therapy. But also the FAA distinguished between positive and negative valence of music emotions during music listening, as Laurel and colleagues found out here or showed here. And has also been shown that the FAA fluctuates in the order of hundreds of milliseconds and presumably reflects activity in amygdala, anterior cingulate cortex, and dorsolateral prefrontal cortex. So in sum, the FAA is a widely used marker of emotional processing and could potentially be useful for us to investigate music therapy processes. So we recorded the EEG from therapist and client, each 32 active electrodes connected to one amplifier, relatively standard pre-processing steps. So I'm just going to skip over them. And then we segmented the moment of interest into 1 second epochs, 500 milliseconds overlap, artifact rejection, and after that followed standard procedure to calculate the FAA, current source density transformation, and then calculating the FAA as has been done in other studies. And yeah, so here are the results, or some results of that. So we have the 2 FAA time series of patient and therapist during this first moment of interest that all raters agreed upon. And I will play the video in a second, but just to give you some context in case you couldn't understand earlier. So in this sequence, the patient first talked about some negative, angry emotions relating to her family and her own pregnancy and her son's birth, and angry because her mother was very critical, and because she was not married, the patient, and the mother even asked if she couldn't have it removed. So, but then later the parents were very loving and caring during the pregnancy and after birth. Yes, and after that, talking about her own history with her own parents, probably the image of her grandmother emerges, who was a very important and supportive person. And it culminates in a message from her grandmother telling her not to worry too much. And this roughly coincides with this largest peak in the whole sequence around here. So I'm just going to play the video so you will see, hopefully, yeah, the time course of the FAA simultaneously with the video.
But it was the first one came to her mind, what will other people think? But when I was pregnant, they were very, very careful and they loved Andreas, both of them. This is nice music. Like something coming from my grandmother's singing. Like she telling me not to worry so much.
Stop here, but maybe you also noticed, or maybe not, I don't know, but at certain parts it seems like the temporal dynamics of the 2 FAA time series appear to be related, so that the peaks in the patient's time series in this case are related but lagging the peaks of the patient time series. So roughly on here, so you have 3 peaks before the largest peak, with the grandmother and the message, and with the therapist and the green line, you have very similar shape of the time series. So just as a qualitative observation at this stage. But based on the comments of the therapist that she felt very connected during particular segments, we also explored possible relationship between emotional processing that goes beyond a purely qualitative description. So we calculated the cross-correlation between the FAA time series during those moments that has been mentioned by the therapist. And indeed, we found a significant cross-correlation for like 0 and -1 during those moments, which you can see here in this slide. And one idea here was that these findings, this pattern that we see, might indicate the shared emotional processing during those moments. Okay, so the second explorative case study is with a patient receiving active music therapy in stroke rehabilitation. But here it is important to note that the music therapy was a relationship and resource-oriented biopsychosocial treatment concept, which follows a very personalized approach in order to accompany people after stroke through their recovery and new self-discovery process. So movement training and motor rehabilitation are not in focus, but rather addressing psychosocial needs of the patients after the potential traumatic event of a stroke and the huge impact that can have on patients' life. So the patient was a 48-year-old male, 7 months post-stroke, who also had a pre-existing Parkinson's disease, and and he received treatment in an inpatient rehabilitation center for 3 weeks, including music therapy. And again, as in the previous study, after the session, we asked the patient and the therapist to watch the video recording and to identify 3 to 5 moments that they deemed to be interesting for whatever reasons that stood out to them for some reason. And they were also interviewed then about their reasons and choices of those moments. And again, we find in the first session one overlap, one moment that both thought was interesting, and in the second session, 2 moments. And again, the EEG analysis then focused on those 2 or 3 in total overlaps. And again, we calculated the frontal alpha asymmetry, and to give you some snippets of the interviews from the therapist, she said it was a moment of encounter for her. It was a beautiful moment, and the shaking of the hand stopped. And after that sequence, the patient opened his eyes, and he said he had been at a very nice place. And the shaking of his right hand was a very important topic during other moments in the session. And also in the interview, for example, he told the interviewee that the interviewer that was a great session because afterwards he had lunch and he could eat his soup without any shaking and without, how do you say that, if you lose food on your clothing. So he was very positive about that. And the patient said himself it was a moment like in Tai Chi, and he had a feeling of an energy ball between his hands, and he could feel the warmth of that energy ball. And this is the FAA time series again, roughly 45 seconds long, and just again purely qualitative observation. It seems the second half, or the first half, we have a more antiphasic pattern, so we have a peak in one person and a trough in another person, and then that characteristic seemed to change after the middle, after this large peak, where both lines evolve more simultaneously, so go up and down together in parallel. And here's the description of that sequence again, but I'm just going to play the video. And just to let you know, this black circle highlights the highest peak of the FAA in that whole sequence, which occurred simultaneously for patient and client, patient and therapist. now he's opening his eyes and they were chatting for a little bit.
Wo waren Sie? Ja, danke.
Right. Okay. And in the third EEG hyperscanning case study, we focus on a single session of improvisational music therapy with a client with early onset Alzheimer's disease, who used to be an amateur drummer but had to stop performing. And again, after the session, we asked 3 therapists to identify any interesting and non-interesting moments. And comments, for example, included there was a change in playing style from less together to together. There was a meaningful musical exchange or apparent lack of engagement. And these individual ratings of all raters taken together suggested a relative difference in how the 2 drum improvisations within the session were perceived. So accordingly, we classified the first drum improvisation as a moment of interest and the second improvisation as a moment of less interest. And finally, our questions about differences in neural coupling between those 2 different moments, and also about differences in quantitative descriptors of the improvisations. And again, we recorded EEG, and to assess neural coupling, we used the so-called integrative coupling index, which is an asymmetric index for positive phase synchronization and indicates the anteriority of one phase time series over another. And this has been used by Victor Müller and colleagues several times during music playing together, but in a non-therapeutic context. And this index was calculated for 10-second segments, first for all 4,000 electrode pairs in 12 frequency bins, and then we had some first explorative data analysis, and results showed that there were only differences in 2 and 4 hertz, so we analyzed only those frequency bins in more detail. And for the descriptors of the improvisations, because also, as Giacomo mentioned, behavior, so we need to look at not only neural data, but also at behavior at the same time. So we used, in this instance, note density, the amount of notes per second, pulse clarity, how easily listeners can perceive the underlying pulse, and synchronicity takes individual features into account, but then estimates the strongest periodicity that is common to both players. So related to pulse clarity, but estimated on the common pulse between individuals. And first we looked at the overall characteristics of these features averaged across the improvisations, which showed several differences. For example, that musical synchronicity was higher during the moment of interest compared to the moment of no interest. And consistent with this, pulse clarity of each interactant was higher during the moment of interest, but did not differ between the players. And note density, so a measure of the moment-by-moment rhythmic density, differed during the moment of no interest between client and therapist. So this indicated that they both acted musically more similar during the moment of interest. And next we took a more detailed look at the temporal dynamics of these features combined with imitation diagrams. And I'm not going into a lot of details here, just to highlight that this kind of enabled us to visualize certain points in the improvisations, in the music. That also has been partly mentioned by the raters. For example, here in this part of the improvisation, the therapist is first leading in terms of note density, and after a section of mirroring, following of rhythmic patterns that were introduced by the therapist then introduces a steady beat to which the client joins in shortly after, and they play synchronously for several seconds. And this is kind of, if you look at the synchronicity marker, this is here, relatively low, and then there's a sudden increase, a peak in synchronicity. And this occurred when the therapist introduced the steady beat and the client joined in. And you can take that further and to micro-analyze the improvisations. But we want to look at the EEG data as well. So Interbrain coupling, 2 Hertz, left therapist, right client. First during the moment of interest, red lines indicate functional connections from the therapist to the client, and blue lines vice versa. And what we found here is that during the therapeutically more interesting segment, there was an increased coupling in 2 Hertz. And this was mainly due to connections originating from the therapist's brain to the client's brain. So synchronized brain activity of the therapist preceded brain activity of the client. And for the intra-brain coupling, we found that for the therapist, coupling was higher during the MONI, and coupling was stronger over central frontal areas. For the client, there was a different pattern, namely coupling from frontal and central areas appeared to be stronger during the MOI, actually. And besides those results in 2 Hertz, we also found, we found a different pattern for 4 Hertz oscillations, namely for between-brain coupling that was stronger from the therapist, but no difference between MOI and MONI this time. And within-brain coupling was stronger for the therapist during the MONI, and for the client there were no differences. And given the coupling results in those low frequencies, which are very close to the kind of tempo of the music and the improvisations, seems likely that this is related to the improvised music and the different sensory motor coordination patterns. But one has to keep in mind this is a therapy session. Making music is happening within a certain situational therapeutic context and for a purpose. And for example, a therapist often aims to support the client in their playing, especially at the start of a session. So the therapist's attention is governed by a certain therapeutic intention. Plus, there were a lot of extra musical social behaviors, such as social eye gaze, laughter, which we did not analyze in detail. So I'm following this reasoning and the interviews, the video, and previous literature, including study by Giacomo and John. One could speculate at this point that also higher level interaction qualities have contributed to these effects. So for example, the therapist is more focused on the client and the interaction, while the client is more focused on himself, or even that the therapeutic or musical interaction is more related to the coupling in 2 Hertz, and the therapeutic attention to the client's playing might be related to 4 Hertz coupling. But speculative at the moment, so we need to do some more research. But to summarize the 3 case studies, first 2 studies showed, we focused on emotional processing, suggested that temporal dynamics can be related to therapeutically important and relevant moments, and also that the identification of these moments or agreement between raters is possible in the first place. That was also interesting and good to see. And in addition, the 2 FA time series seem to be related to each other at times, but which might be a form of shared emotional processing, which would fit with some experiences expressed in the interviews. And for the improvisational case study, main finding was a stronger coupling, neurosynchrony during the MOI compared to the MONI, which is perhaps related to interaction quality and or musical differences. So all in all, that led us to believe that EEG hyperscanning combined with detailed audio, video data, but also qualitative data, so the experiences of participants, of patient and therapists, can be a promising tool to investigate music therapy processes. And with that, back to Jörg.
Yes, so given we started a little bit later, so we still have 10 minutes, I guess, right? Yeah, okay, good. So, well, this is what we've done now, let's say, in single case studies. Of course, we were interested how that looks like when we do that in a hospital setting, and with, let's say, still a small N study with 12 patients in this case. And so we've done, first of all, we tested our equipment for the clinical context. We're together with a group in Austria. And there we, for instance, did mock sessions with medical actors from the University of Vienna. And then did a feasibility study, going to speak about that, where we try to find out how that implementation of a mobile EEG hyperscanning setting would work. And then finally did that small N study where we were having 3 weekly music therapy sessions, and published about the feasibility study, because that's in stroke patients in phase C, so you can work with them 180 minutes on a consecutive way. And we were considering daily routines, room size, equipment, and find a way how we can make that happen. As you can see, 2 suitcases, that's what we were bringing into the bedside, in a bedside manner, and build up our lab there. Yeah, I can hear that. Right, so then we were looking into our planned and actual durations. So we were thinking, well, for all of what we are doing, preparation, and then the measurements with the EEG and ECG and video recording and the setups, we would take all in all like 96 minutes. And then also do the video ratings and an experience screening. So how did you experience the sessions afterwards? And then the interviewing. And you can imagine from what you've heard already before, that looks like it could be like a longer time. But, well, on average, we were good. So 155 minutes, that's what we were achieving, including the break. No, excluding the break, of course. And just because if it's for patient benefit, you can't, let's say, burden them. And questions that were given for the patient participants: so how did you experience the research setting? Were our instruction and question comprehensible for you? Was working with a computer while watching the video and selecting the noise acceptable for you? All these kind of practice questions that come up in such a setting when you go on the ward. And would you encourage others, and so on. And then, of course, the MOI ratings. We've done that already with our case studies. But here then, because we were wondering, will they really understand what we want from them? When we were asking them, look into the video, so what do you like? Well, how was it for you to do that? And so we were writing all that down, the average durations of the moments that they were identifying, and the average. And so that was the feasibility study. But now where we are right now, we have 132 MOIs from the patient's perspective, and then 135 for that small N study with 12 diets. And 50 MOI overlaps, and with the same moments rated as interested by patient and therapist. And the majority of the 31 sessions was at least one overlap. How we did that? Well, and we had these 31 sessions, and then video recordings done, and then analyzed this moment interest selection. Then qualitative interviews were done and analyzed in this way. How we're showing that here. So grounded theory analysis. So yes, we have a mixed method approach here, where we try to really go into getting more out of these descriptions, so that we can also then relay that to our EEG recordings, which were done, of course, in each of the sessions. And for instance, what happened in the sessions, so 38% talk, 32% active music therapy making, then listening to music, 15%, song singing, functional exercises. This is a different approach, I'd say, so as Clemens already said that from the beginning. And then when interviewing and analyzing these moments, what is important for a patient? So emotional experiences, in 72 moments of interest, it was 55%, it was of importance for them. Experience of joy in the corresponding MOI. And then personal themes, body experiences, interactive process, musical togetherness. So that was that was the categories that were drawn out of this of the qualitative analysis there, done, as I said, with this multimodal interaction analysis. And then also what the therapist was selecting: interactive processes, therapeutic interaction, musical interaction, and interpersonal encounter. And so this gives us a quite good base on what is happening in these sessions, so that we can look if there is something that is of more general value. there, but based on that practice data that we have created and then analyzed, and have the qualia, the context of the experience of patient and therapist, so that we know what is in that session happening. And then we're doing a microanalysis, which was quite interesting, or shifts in the session, of sessions that had at least 4 more overlaps. And how many of these shifts were patient-led, and of course that is something that we will analyze. And profile of Moyes could go into their details, but it's somehow what we have already seen in this. But this is where we really have an overlap between. So the experience of joy in this case and musical togetherness was something that both were sharing. From a related study, but with a different patient pool, we were then, and I'm coming to an end, using ECG and the motion energy analysis from Chacha, and collaborating with Ramsay, and also analyzing the synchrony of movement and heart rate synchrony. So what you see here is a pre-talk that before the session. So what do you want to have to happen today? What is up with you today? Then you have the intervention, and then we have the post-talk. So this is a quite good setting, pre and post-talk, as it is in a psychotherapy, and used from Chahar and Ramsay to study the pixel changes to create a time series and understanding of how these particular regions of interest change to come up with a value of synchrony, motion synchrony, non-verbal synchrony they call it, because it's motion-related synchrony in the therapies. So that's what we were looking at. And results from 11 diets suggest that it was higher non-verbal synchrony after the music therapy sessions. And then when you're comparing non-verbal synchrony in pre and post-talk, it showed that the patient leading increased from 2 cases in the pre-talk to the 7 in the post-talk. So 9 out of 11 diets showed an increase in non-verbal synchrony after music intervention. Non-parametric tests indicated that non-verbal synchrony, all X, was significantly higher in the post-talk than in the pre-talk, which is quite interesting that after the music session, they were more synchronized and patient leading. That was an interesting observation, which is different in psychotherapy, where it's still therapist-led towards the end, as Chahar and Ramsay then also kind of conveyed. Then, I'm aware of time, that's why I'm trying to be a bit quick here. So, using the ECG recordings and looking at the time series and the cross-correlations related to that. And one of the outcomes of that is, well, the heart rate synchrony was significantly positively associated with duration of the intervention, and then also correlated to the highest heart rate synchrony value of each diet, and negatively correlated to the lowest heart rate synchrony. So long story short, what we look at here is an average heart rate synchrony for all of the diets, and that's expressed for each of the diets then here, and then an average highest heart rate synchrony, as you can see that in the black bars there. And what is interesting for us here is that it takes 25 minutes to have this high values when you start staggering them in that way that we had the number of top 5% and the highest heart rate synchrony logs, and they seem to occur after 25 sessions. So it needs a particular time to go into that process of synchrony. And why am I showing this as well? Is because when we're looking at our ratings, at our moment of interest ratings here, you can see that there's a density of ratings towards the end, towards the 25 minutes, and also a density related. So these are from the 12 diets, the ratings from each of from the therapist and the patient, and then there's a corresponding overlap, which also then has a density in that area. So that was something of interest for us, and an argument to say, well, it needs a bit of time to go deeper into the session. Right, okay, so coming to the conclusions now. Okay, moments in therapy that have different qualities and meanings for the client, but also within the client therapist diet can be captured and described on a neural level. We've seen that individually and dyadically within a hyperbrain. There's preliminary evidence that, for instance, alpha symmetry, cross-correlation, and temporal dynamics of event-related peaks during shared emotional processing is associated with therapeutically important moments, and higher brain-to-brain synchronization during important moments of interest in improvisational music therapy, emotion-related entrainment and synchrony during pre- and post-talk in a music therapy session, and increasing heart rate synchrony during music making in the session. So this multimodal approach seems to be quite promising one. And yeah, so of course there are limitations. Case studies are indicative and not conclusive, indicating specific aspects related to music therapy process, and described process units needs more experimental testing. So we're coming from the practice and then describe modules that we then can test in a more experimental setup. So, but with the data which is gained in the practice. So naturalistic real-life settings versus the interpretability of multimodal mixed method data sets. Yeah, and of course, there's a lot of work on the EEG monitoring, where we have 3 cameras, and then movement detection and artifact removal. And I think, I don't go through all of this now. What do you think? Shall we? I mean, we have to investigate more temporal resolution of musical features, interactive behaviors, longitudinal studies, changes over time and social interaction, and yeah, relationship to change factors, theorized mechanism of change. Yeah, well, that's, and change process, outcome research, relationship to therapy outcomes. There is a lot of things which is still possible, and as we're discussing, of course, real-world settings, so to get to a full real-world setting, well, going into the hospital, of course, gave us extra problems, but at least it was the situation where the patients were, and making that possible, and yeah, considering what needed to be looked into. Well, future music, well, that's what we are actually talking about. Well, so NeuroMusic supported music therapy assessment, because what we were showing you is how we assess our sessions. And I'm pretty sure that with all these indices that we are looking at, there's a chance to support that subjective nature of how we analyze our session. But there's several ways of doing that. And one very interesting bit was shown from Rafael Ramirez on the Music and Medicine conference now in Berlin, where he created a valence arousal panel that you could see as a therapist while you're doing your job, and then the heart rate, the heartbeat, in a heart, and then the breathing pattern. So long story short, while you're doing the therapies, you have that neurofeedback situation that you can see, oh, the patient is now drifting into more like a negative emotional state, or is hyper-aroused or whatever, or hyper-aroused, and heart rate is going up. So while doing the work, and just imagine you have the glasses on, where you have that data transferred to, so there's a lot of possibilities where all these kind of praxeology, which is the measure of how we're doing our practice, or how we can make use of these multimodal data sets in future, and yeah, to develop more of this mobile lab developments to support music therapy assessment practice. And yeah, I love that socialized so much yesterday, because when you imagine you have a therapist and we have recorded EEG hyperscanning and just have the glasses on, and then analyzing the video later on. So where is he or she looking at? What is it that is of interest? So it gives more data to that process, so that we can make use of all the gadgets that we were getting. And now it comes, the main bit. Thank you. So, it was right.
Thank you both of you for such a wonderful talk and such a big overview of a huge body of work. It's so many studies over such a long time, so much data, the multimodal data. I mean, I was very curious even how you're organizing that, or what the software was that seems to keep all of that in one cohesive place, but I'll let others ask questions first. Any questions? Yeah. Alex, is that? Yeah, okay.
Thank you for, as Lauren said, a great overview and intro for me to music therapy. I had a question on case study 1, so I think it might be technically more for Dr. Maidhof, But we saw in case study 1 with the FAA data a huge spike followed by actually the deepest trough of the data. Was that a pattern that you saw often, that it would be the highest moment of interest peak immediately followed by a deep trough, or was that a one-off case? And do you have any idea what that would mean?
Well, first of all, I would say that what was interesting that during the deep trough, the imagery of that grandma came up, which was quite interesting, and then it was gradually building up, along with the building up from the therapist, and then it came to this high peak. And I'm not sure if you're referring to the lower peak later on, or to that lower peak which is related. Well, I should go back to the slide then. Where are you? Come on. Oh no. I just can't see my cursor, sorry. So anyway, so there was a deep curve, and that is something, well, I would say, well, this is the first time more or less described, that there is this lower, that negative emotion as it is displayed with this resolution that we've chosen for the FA time series, and then with the building up of this high peak. But this pattern that we observe a unit in which you obviously know as a therapist, well, now something of an insight has happened. And in psychotherapy, this is what you would be sure about. Okay, the patient has understood, has something experienced which is of importance. And that can come from a negative emotional peak. We were surprised, but in general, I mean, it's therapy. It's not happy-clappy listening. It is really, going deep into problems. She was really in fear that her grandson would not appear on this earth, and that her granddaughter-in-law would be dying. So, of course, there was negative emotions, but this message from the grandma was kind of really the conveying, okay, there's hope, and to tell, well, the boy came out into the world, and they're all there still. But yeah, I can't say. But in our other pattern that we were looking at, it was a little bit in antiphase at the beginning, and then it was more or less synchronized, graphically looked at. There were, of course, also some ups and downs, but that kind of microanalysis we have not gone into in that detail to really say, well, that's something that you can always. But of course, is what we are hoping for, that we would have that data. Well, that gives us some kind of prediction for for that model that I was just kind of showing from Raphael there. Right.
Maybe. Hey. Thank you both for the talk. I had kind of two related questions about standardization. As well, one of the goals is that we want music therapy to be something that's consistent across patients, and I really appreciate your approach of making it patient-centered. And so my two questions are, one, how do we deal with differences across music therapists? Is that something that's a concern? Like, would the same patient have very different experiences with two different music therapists? I'm not a music therapist. I'm just kind of curious as someone who studies music cognition. And then my other question is, you talked a lot about moments of interest. And I'm curious if there's a way, maybe in the future, to try to reconcile these moments of interest with things that people typically measure as kind of pre and post those outcome measures. So, yeah.
Yeah, I mean, that's why we brought this up, of course, to say that I'm pretty sure that when we have more descriptions from these, let's say, praxeology-driven outcomes, that we would be able to kind of identify such patterns in a way, given, of course, we have some brain indices that we are analyzing there and data. So I think on that end, yes, that would give us, training, of course, the data sets. That's why I reached time series analysis of therapies. If we would have more of that, I'm pretty sure that we can identify And that's what we're actually also working with our hospital study, to identify what is kind of a core bit in there. So I'm not sure if that's answering that, but to the first question, of course, there's always variability of the patients, and that is what we were just discussing with this nomothetic and idiographic, because the error is, of course, what the patient is expecting, the trajectory of his or her experiences. So it works well when we have a pre-post measure and an outcome measure. That works very well for that model of the, let's say, RCTs, where you try to look at this variability and the variance and analysis, and then can compare that to other, let's say, physiotherapy or whatever kind of competing intervention that there are, to say, well, what is better for this depressed patient or what is better for that patient. So on that end, it is possible, but within the sessions, it is Monday morning, 9 o'clock, it is Friday afternoon, whatever, and you have this particular set of the patient, how he is, and then you have that setting in which the therapy is happening. So you're always dealing with that. But this is where it happens. The art is always opening a window for a moment and it shines through. Sorry to speak that stupidly, but that's where the grandma then may start talking. I'm not sure, maybe you want to add something there?
Yeah, but I don't know if you have time.
Well, will we stop from her?
Yeah, we started late, so
Yeah, actually, about the relation to the moments of interest, I mean, that would be one of the next steps to relate that to the outcomes within a larger study where you collect idiographic data of all patients, but still collect the same outcome measures. And at some point, we need to look at both things together and in what relationship they are. But at this point, I think it still makes sense to look at on the individual level to understand and to not approach the question of what is the best treatment for a certain client population, but to look in the individual level, because there's huge variety. Everyone is different, and if you look at patient-centered approaches, then it makes more sense, or not more sense, but it makes sense to start on the individual level. You can also, it's a little bit comparable maybe to musical creativity. So this is also a hugely individual thing, and everyone is different. So there's also this plea of, actually maybe it doesn't make a lot of sense to make big studies in musical creativity because it's very unique for each individual. So we lose a lot of information if we look at group averages.
Time.
great. So I would say there's time for one short question, and while that question is being asked, I would ask all of the speakers from yesterday and today to come down so we can start our panel discussion directly after. So if there's one more short question for Jörg and Clemens, we'll take that now, and John, Laura, Laurel, if you could come down. No other questions? Okay, well, you can continue to ask questions in the